glad to be able to be joining you all tonight and really excited to share this really important topic. It is one of our most requested topics that we hear patients ask about is what does perimenopause mean? What does it look like? And do I have to just suffer through this? And the good news is tonight we're going to be talking all about no, you do not have to suffer. There is absolutely a better way forward in order to manage this time and this transition. And we're going to talk through tonight what this looks like to be going through perimenopause, what are the symptoms you may be experiencing, as well as give you some practical tips that you can take home tonight in order to be able to really thrive in the transition during this time frame. So can't wait to get going with this. A couple housekeeping pieces. Please feel free to use comments. I do try and monitor those throughout our talk tonight. And so if you have any questions that come up, especially about a particular slide or a particular question, don't hesitate to respond there. You can also send me a direct message through Facebook Messenger. Those I will get to after the event and be able to respond back directly to you. And looking forward to being able to share all of this information with you tonight. So let's get started. And talk all about perimenopause, such an important topic. So a little bit about myself. For those of you who don't know me, I am a family medicine physician by background, and I've been practicing since 2012 in the Cedar Rapids, Iowa area. I do provide telehealth services all across the country as well. So if you're joining us from another state beyond Iowa, chances are good I may be able to take care of you in another state as well. I did receive additional training beyond just my normal family medicine training in what's called restorative reproductive medicine. And so there's different kind of brands or types of restorative reproductive medicine. So I've kind of done it all. I'm kind of a junkie when it comes to this because I'm so passionate about women's health and helping women to really understand what's going on with their hormones. So I have received additional training in neofertility, fem, and NAPRO technology. And back 2 years ago in 2023, I actually founded and opened Radiant Clinic. And so our whole mission there is a multidisciplinary clinic where we provide not only medical services, but also hook up women with charting instructors for fertility awareness method instruction, health and hormone coaching, as well as that medical evaluation and treatment. And then I also do have a podcast. It's called Cycle Wisdom. And I do put a little asterisk there throughout tonight's talk. You're going to hear a couple of different episodes that may be referenced. So if you're interested in learning more about a particular topic, there are some episodes that dive a little bit deeper into kind of what could I do or what do I need to consider or think about if that's the case in order to really understand more about this. So I always like to get started with some true or false perimenopause facts because I find that's one of the most challenging pieces is that women oftentimes don't really know what perimenopause is and they aren't really told and they get bad intel even from some of their well-meaning healthcare professionals. So we're going to start with this. True or false? Perimenopause can start as early as age 35. So this is actually true. In some women, it can begin as early as 35. The majority of women, it's going to be a little bit closer to 40, but it usually can say, hey, anytime 35 or later, we can start to see symptoms of perimenopause. True or false? Perimenopause lasts only 2 to 3 years. This is false. In many women, it can last even up to 10 years. So I'm sorry to be the bearer of bad news, but in some cases, there can be these symptoms that go on for many, many years. Some women experience no symptoms, so don't worry, it's not for everybody, but it can absolutely be more than just a couple of years. True or false? During perimenopause, you can still get pregnant. This is true, and it's one of the biggest concerns that I get from a lot of my patients, especially in their 40s. They're maybe completed with their family size or are just really nervous and anxious and don't want to get pregnant for many different reasons. And so we'll talk about what that looks like a little bit tonight and how we can kind of navigate those changes without just completely suppressing your hormones. True or false? Hot flashes start during perimenopause. This is kind of a trick question, and I'll say maybe, meaning that not every woman experiences hot flashes, and it's not a specific sign when it comes to perimenopause. In fact, hot flashes can be a really important part that can clue you in that there may be something that's going on with your hormones that's not okay. Ultimately, I would say hot flashes, although they are common, do not have to be normal and does not have to mean that you are just suffering through them. So if you are experiencing hot flashes, at any stage of the game, that is something that is medically important to bring up to your healthcare professional. And true or false, perimenopause requires that I go on birth control to regulate my cycles. And I'm also going to say false with a couple of exclamation points here. So often women are told that this is your only option is go on birth control. It'll help regulate your symptoms. It'll help straighten out your cycles. And the reality is that especially during this time frame, hormones can be really volatile. And so sometimes birth control can actually make things worse. It can also potentially cause side effects and symptoms that are unwanted, especially things like decreased libido or changes in your cycle, which a lot of women are already experiencing. So we're going to talk through some ways tonight that you can evaluate, do I have perimenopause? And if my doctor is telling me that I have to go on birth control and that's the only option, what are some other choices that I might have? So I do want to offer just a couple of disclaimers here. First of all, names, data, and charts have been de-identified. So oftentimes when I give these presentations, patients talk to me afterwards and they're like, was that me? Was that my story? And it's not your story. A lot of the times I kind of am mixing different pieces and parts of different stories, but everything is de-identified. So you're not going to hear any actual real patient names or data being shared. More importantly, the information that I'm presenting tonight does not constitute medical advice. So even though I am a licensed healthcare professional, I am not giving you medical advice at this point in time. So if you decide you'd like to work with us after this is done, we'll talk about what that looks like, or you can go back to your own primary healthcare professional in order to just be more educated on this. But it's so important to know that the case that I'm going to present tonight is not the blanket treatment statement for everybody. And it's so important to make sure that treatment and evaluation are customized to your unique needs. So I'm going to start with sharing Ruth's story. Now, Ruth came to me at 43 years old and she was having heavy bleeding with her periods. Prior to that, she had had fairly regular cycles about every 30 days, but really in the past couple of years, she noted that things were getting quite a bit worse and she actually was bleeding every 2 to 3 weeks. So cycles were happening closer together and they were much heavier. When she wasn't having bleeding, she was noticing continuous mucus discharge and was starting to have some hot flashes at nighttime. She had also noted that she had gained weight about 15 pounds in the past 2 years. And I don't think I included it here in these bullet points, but Ruth also was dealing with some decreased libido, feeling exhausted, and also starting to notice some hair loss. So maybe this sounds familiar to some of you. And again, you don't have to have all of these symptoms in order to be able to qualify for perimenopause, but those are just a lot of the pieces that we do notice. Ruth's family history included her mom had gone through menopause at age 51 and her older sister had gone through menopause at age 49. Now, menopause is actually when the periods completely stop. So that's a little different than perimenopause. But it's important to know this because oftentimes your menopause journey will follow similarly to what mom or older sisters are. There are absolutely different things that play a role, but we always say it's good to kind of know when that happened so that you can kind of have a heads up. So this is just presented for illustrative purposes, and this is an example of a normal fertility chart. So we're not going to talk about normal charting tonight, but all this to let you know that this is what a normal chart would look like. So what we're seeing is a cycle that's lasting anywhere from 30 to 34, 32 days. Each of these days is an actual day of her particular cycle. We see a normal bleeding pattern lasting about 5 to 7 days. Then it's followed by some days that are dry, followed by a fertile window, and then followed by some additional dry days. So this is a fairly normal chart. Now, for comparison's sake, this is what Ruth's chart looked like. And you can see here, it's definitely not anything like our normal chart. So lots of bleeding that was happening, lots of mucus that she was experiencing, and she really didn't have any days that were considered quote unquote normal. So basically just tons of bleeding, tons of mucus, and really just a cycle that was really, really challenging to kind of figure out, but also really frustrating from a standpoint of, hey, I am trying to not be bleeding all the time and ideally not trying to get pregnant during this time. And so for those of you who may have some familiarity with charting, when we have continuous mucus, it can be a sign that we're fertile. And so this was really problematic from the standpoint that Ruth did not want to try and get pregnant. So we knew we had to do something pretty significantly. So let's back up a little bit and talk about those different stages of reproductive aging. And really, I want to compare and contrast perimenopause and menopause because I think this is where a lot of confusion happens. So again, as we discussed in the introduction, perimenopause is the 10-year time frame or up to 10-year time frame prior to the onset of menopause. And for most women, that's somewhere between age 35 to 50. Your periods can change during this time, and sometimes they can be shorter, sometimes they can be longer, sometimes they can start happening closer together, sometimes farther apart. And really, we just start to see significant fluctuations that can unfortunately be all over the map. The reason this happens is because of fluctuations in estradiol. So, estradiol is one of the forms of estrogen we have in our body, and it's the primary source that we have when we're in our menstrual cycle years. Now, menopausal symptoms may start to begin during this time frame because of those fluctuations in estradiol. The other lab change that we find is you can start to have a mild increase in FSH, or your follicle stimulating hormone. Again, this is a hormone that helps tell your body when it is supposed to ovulate. And so we start to see these fluctuations in estrogen levels, the mild increase in FSH during this time frame that we call perimenopause. Now, let's contrast that with menopause. And menopause average age is about 50 worldwide, but it can range anywhere from 44 to 55, and some women beyond that even. The actual medical definition of menopause is having one whole year without any menstrual cycles. So it's sometimes challenging to wait that full year before we say, okay, you are officially in menopause. However, menopausal symptoms typically show up within less than 10 years afterwards. So it's most common that you're going to notice some symptoms as you're going through that menopausal transition. And again, there's further decreases in your estrogen levels as well as further increases in FSH, or follicle stimulating hormone, because your body is trying to send additional stimulating hormones to stimulate those follicles in order to release an egg. So what that looks like is this lovely graph here. And so I'm going to orient a couple pieces. So the first thing we see is these fertility years. And really what happens during these fertile years is estrogen, which is denoted by this kind of light brown line, and progesterone, which is denoted by this green line. They are typically fairly well balanced and in a really good range. However, what happens in this perimenopause transition explains, I think, what a lot of women notice is that things can kind of just go all over the map. And this is your estrogen levels. Sometimes they run a little too high, sometimes they run a little too low, and they can really just kind of cruise all over the place. Whereas typically for most women, progesterone levels start to take a decrease over the perimenopause timeframe. And again, we see this follicle stimulating hormone, this is this darker gray line, start to increase, and luteinizing hormone, which follows, and it's kind of a cousin to this follicle stimulating hormone, also increases. So this perimenopause time, as you can imagine, is literally this roller coaster of what's going on with your estrogen levels, which oftentimes explains a lot of the symptoms that women are experiencing. Now, when we get to menopause, the good news is things level out quite a bit. So FSH typically remains high, and then estrogen levels as well as progesterone levels are typically low. So the good news is, from a stability standpoint, hormonally things are much more stable, but this is also part of the reason that women have so many symptoms during menopause, is because everything is low with your estrogen and progesterone. So let's talk a little bit about the physiology that happens. And again, I'm not going to take you back to high school chemistry or anatomy, but part of what happens is that your ovaries become less sensitive to that luteinizing hormone and follicle stimulating hormone when you hit menopause. But that isn't just a trajectory that happens overnight. It is this slow, gradual change that starts to happen during perimenopause. And that oftentimes will lead to increasingly abnormal ovulation. And so some cycles you may have a more difficult time ovulating, some cycles you may not ovulate at all. And again, ovulation isn't just about fertility. It also tells our body and triggers our body when we are supposed to have our next menstrual cycle. So if that ovulation is impaired, or your body is having a more difficult time ovulating, that is going to then change subsequently when you have your next period. This creates what we call a luteal phase deficiency. So luteal phase is when you should ovulate until the time of your next period. That's your luteal phase. And generally, when we don't have ovulation to trigger that luteal phase to take off, then we start to see deficiencies in the hormone levels during that time, especially with progesterone. So we're going to see hormone changes in both the estrogen and progesterone in response to this, but really, depending upon your unique situation, helps to decide what do we need to do in order to treat things. So I like to show this pictogram to kind of talk about how we balance hormones, because I think a lot of people hear that term balance hormones, but what does that mean? It doesn't mean that my estrogen and progesterone are the exact same number, But what it means is that relative to each other, both my estrogen and progesterone are in a nice normal range. So when I talk about a balanced hormone cycle, I'm talking about estrogen that is in normal range as well as progesterone that is in normal range. So there are two different scenarios that oftentimes happen during perimenopause that can make things imbalanced. So the first is what we call estrogen dominance. And in this situation, you can see we have a lot more estrogen, but we have normal progesterone. So this can cause estrogen dominance if we just are producing way too much estrogen. And as you can imagine, part of our treatment course here is going to be we want to try and get rid of that excess estrogen. Now, we don't want to block it completely. We absolutely positively need estrogen. It is crucial and important for survival as a female, as well as for lots of other good health reasons. But we do want to help balance it because estrogen dominance can cause a lot of symptoms, and we'll go over that after this slide. The other piece that can cause this is also termed estrogen dominance, but you'll notice this picture is a little bit different. So in this case, the estrogen levels are actually normal, but the progesterone levels are quite low and decreased. Now, either of these situations can still present as estrogen dominance, but it makes a big difference knowing what type of estrogen dominance you have in order to know how to appropriately treat your symptoms. In this second type of estrogen dominance, our treatment course would focus more on increasing your progesterone levels so that we can balance out the progesterone and then stabilize things and balance the hormones in that way. So estrogen dominance, like I said, very, very hot button term that we hear all the time, but it's really important to know it's about more than just one thing, and it doesn't always mean that you should just be blocking your estrogen, because especially in this second situation, if you are blocking a normal amount of estrogen, you're actually going to be more deficient in estrogen. So please, please, please do not go and just start blocking your estrogen intake until you are working with a healthcare professional who can tell you what type of estrogen dominance do you have and what makes the most sense for treatment for you. So let's go through a couple of perimenopausal symptoms that people may experiencing. And this is not a full list, but it is typically the most common things that we see in our practice. So definitely an increase in PMS symptoms. So PMS symptoms are common, but they are not normal. It is not something you have to suffer with. And the most common things we see with these PMS symptoms are going to be carb craving. So I'm feeling like I need to eat a bunch of sugar, irritability, breast tenderness, and sometimes just straight up moodiness. And I don't want to even talk to people, or I'm really angry and cranky with life. Typically, the way that you know this is different from just normal baseline irritability is that almost always these PMS symptoms will resolve within 1 to 2 days of your next menstrual cycle starting. So that's a really good way to know, hey, this is PMS versus, hey, my family is just driving me bananas. Other perimenopausal symptoms include irregular or abnormal bleeding. As we talked about with Ruth's case, this excess bleeding and the increase in bleeding can be really problematic. And so anytime we have bleeding that is not falling within that normal 7 days or less, we want to evaluate that to make sure there's not something hormonally that could be causing issues. Sleep disturbances. This is a very, very common one that we see. It's really challenging to regulate sleep and to tell your brain to just shut off, but sleep disturbances are very common in perimenopause. And sometimes that's because of hot flashes or night sweats. And unfortunately, it's really common to get these hot flashes overnight when our body temperature regulation is kind of off and things are a little bit funky anyways. Changes in libido, very, very common to see this. And sometimes it's because of the estrogen and progesterone shifts that we see, but I also frequently will find a decrease in testosterone levels during this perimenopausal time frame. So there are absolutely things that we can do to help with decreased libido in response to perimenopause during this transition. Generalized fatigue is very common. I don't come across many women who tell me, oh, I never feel fatigued or anything, but fatigue is definitely more common in perimenopause. Again, maybe part of that sleep disturbances, but also your body is constantly fighting that roller coaster of hormones. And so fatigue can be a really real thing. Vaginal dryness, that can be really common, especially as we start to lose estrogen. And concern about fertility. We deal with a lot of anxiety regarding, am I pregnant? Could I get pregnant? If my cycles are really irregular, they're happening only every 6 to 8 weeks. Does it mean, did I miss a cycle? Am I pregnant? I'm taking a pregnancy test when I'm 47 years old. It can be really, really problematic. And so I do want to put a star here on things that are going to be very common, especially when it comes to estrogen dominance. So when we see that they're estrogen dominant situations, oftentimes we'll see all of these things that have the stars on them. Now, the tough thing, as I pointed out in that earlier pictogram, is estrogen can really kind of roller coaster and be all over the map. So challenging sometimes to sort it all out, but that's part of why we rely on not just your symptoms, but also on detailed lab work and history in order to figure out what's going on. So let's go back to kind of what we would observe in those charting observations as we talked through with Ruth. Again, changes in the menstrual flow, sometimes premenstrual spotting. So if you have days where you are just spotting or lightly bleeding before you actually start a flow of menstrual blood, that is a very common sign that we see with progesterone deficiency. Now, this is very common during the perimenopausal time frame, but can happen at any time. And again, there are lots of things we can do to treat this. And so understanding and realizing that premenstrual spotting is not normal can really be beneficial to say, hey, there is something we can do to fix that. Mid-cycle bleeding, again, any bleeding that's happening when it shouldn't be, or cycles that are being skipped altogether. When it comes to our mucus observations or looking at those fertility signs, sometimes we'll see more mucus, sometimes we see less mucus. And really, this is just the cervical fluid that you may notice when you wipe, when you go to the bathroom. Those mucus observations can change. Mucus in particular is very responsive to estrogen. So oftentimes when we have more estrogen in our system, we're going to see more mucus. And when we have less estrogen, we're going to see things get a little bit more dry. Can also cause some early ovulation. Again, when our bodies are not knowing when exactly should I ovulate, sometimes we can see early ovulation and sometimes we can see late ovulation. And so I promise I'm not just a flip-flopper on this, but this is truly what we see in perimenopause and part of what makes women feel like things are so wild because we are on this roller coaster. And so really the standard medical treatment for perimenopause, when women go into their doctors and they say, hey, I'm having something crazy going on with my cycles, most women are told, well, just go on birth control. And that's going to fix everything and it'll regulate things and everything's going to be okay. Or get an IUD. Again, having an IUD oftentimes will stop your cycles from happening altogether. But again, it doesn't correct the underlying issues. Antidepressants are also commonly prescribed. Now, I'm not against antidepressants. They can absolutely be used in the right cases. However, I see them prescribed often as the all-be-all fix for perimenopause. And the reality is if we treat the underlying hormone dysfunction, oftentimes women feel a whole lot better and they aren't needing the antidepressants. And my least favorite response of all that oftentimes patients tell me is, well, tough it out. It's only going to last a short time. This is part of being a woman, so just deal with it. And again, there is absolutely a better way forward in order to be able to go through this time frame. So this is what appropriate medical evaluation would look like during the perimenopausal transition or any time that you're having irregularity with your menstrual cycles. So we always are going to start with charting your cycles. And as I pointed out in Ruth's case, this is more than just tracking when you're bleeding. It's also looking at what are happening the other days of your cycle. Am I observing that I have ovulation happening? Am I observing a fertile window? What else are we seeing that's able to identify, hey, there might be something else that's going on with my cycles? A targeted hormone profile. And so really with this, we're looking to say, what are your labs showing us so we can estimate or guess what's going on? And then we really target in and hone in on when are we going to check your labs and what labs are we going to check to make sure that what we diagnose is an appropriate diagnosis. And then ultrasound, especially if anybody is having unexplained heavy bleeding, we always want to check and make sure there's not something else anatomic going on. So for example, it's common that we find polyps or fibroids or unusual thickening of the uterine wall. And those are all things that require additional evaluation. And so if we're finding unusual bleeding, an ultrasound very frequently is a part of our treatment plan. A full thyroid panel, and I'll show you what I mean by this in a little bit, but a full thyroid panel is more than just checking your TSH level. TSH is a good indicator of the message that your brain sends to your thyroid gland, which sits at the front of your neck, as to are you stimulating enough thyroid hormone production. But it does not tell us, is that thyroid hormone that's being produced getting all the way to our cellular level where it's actually going to make a difference in getting to the cells in order to do what they need to do. So it's so important, especially during perimenopause, to have a full thyroid panel. The two most common times that we see thyroid dysfunction show up, the first is postpartum, so after you've delivered a baby, and the second is around the perimenopause and menopausal transition. Again, when your hormones are doing crazy things, your thyroid is more likely to go out of whack. So it is nature's terrible joke that thyroid dysfunction very commonly also shows up during these times. So important to get a full thyroid evaluation. And then we also always evaluate for adrenal fatigue. So your adrenal glands sit above your kidneys, and they are responsible for production of many different hormones, including DHEA and cortisol. Now, these vital hormones are crucial in order to produce all of the other hormones that come downstream, like progesterone, testosterone, estrogen levels. And so making sure that we evaluate to see, are your adrenal glands working how they're supposed to, is also a part of this process. And then if you are somebody who's experiencing heavy bleeding, we always want to check for iron deficiency. Do you need an iron supplement? Do you have enough? Do we need to get more in your food sources? Or maybe you're somebody who's really iron deficient and we actually need to send you for blood transfusions. And so that's really important to say, do we need that level of care, iron infusions, oral medications, or food intake in order to really evaluate and make sure we're helping to keep up with your blood counts? So general health evaluation during this time frame, it still is so important to keep up with your annual exams. A lot of women start to blow these off when they're in their late 30s and 40s because they think, well, I'm not having babies and I'm, not doing anything else new or exciting. It's really easy to blow those off. So please keep up with your annual exams. Recommendation for most women over the age of 30 is at a minimum pap testing every 5 years, as long as your labs have been normal and HPV is negative. Now, if you've ever had an abnormal exam or you've had an HPV positive test, check with your healthcare professional as to how often you need to get pap smears. But yes, a pap is absolutely still recommended during this time frame. Mammogram. This is the other fun thing that a lot of times people forget about is after age 40, it is so important to get some type of breast cancer screening. I'm a big proponent of mammogram as far as early detection. We have lots of patients that have picked up early cancers that have been able to have surgery and be able to bypass chemo radiation when we get it treated early. So when your hormones start to shift and change, making sure that we're keeping up to speed on all of these other cancer screenings that can be hormonally related is so important. It's also really important to keep up with your cervical cancer and breast cancer screenings because if we are going to treat with any hormone therapy, we want to make sure that we are not causing any additional harm or adding hormones to a hormone growing cancer. We also during this time frame want to make sure that we're assessing for any other cardiovascular risks, so any heart or blood vessel risks, making sure that we're checking your blood pressure, blood sugar, cholesterol levels. All of these things are important to make sure that we're not developing other health conditions that are going to need additional monitoring. And consider bone density testing even during perimenopause timeframe if you have chronic history of low vitamin D levels or a low body weight. Now, most of the time, conventional doctors aren't going to talk about getting a bone density test until after menopause has happened. But we know that the bone density changes can happen even before your periods stop. So it is worth considering and asking your doctor, am I somebody who would qualify for bone density testing? Okay, so let's get back to Ruth's story. So this is just a small snapshot of some of the things that we got when we tested Ruth's labs. Now, I'll point out here, a couple of these pieces were done early in the cycle. So her follicle stimulating hormone, we actually tested that a couple different times for her. Oops, so sorry. So we tested follicle stimulating hormone a couple different times. The first time we tested it was 12.5, and the second time we tested was 5.7. Now, normally we should see that this is less than 7. And again, so one of her levels was a little bit elevated. The other one was technically normal. So again, it's part of that roller coaster that can happen as we're starting to see changes happen. The other thing I'll point out is that early in her cycle, Ruth's estradiol levels or estrogen levels were pretty low. So early in the cycle, they should be somewhere at least 50 to 200, and she was at 43. So we're seeing it start to sneak down a little bit at this phase of her cycle. Her cortisol levels were also a little bit on the low side. So interestingly enough, a lot of women will think, okay, well, if my cortisol is low, that must mean my stress is low. And unfortunately, what we find is that when cortisol levels are too low or on the lower end of normal, it can actually signify that there's been chronic stress over time and your body is actually trying to suppress those cortisol levels. And so we do oftentimes see that your cortisol levels are lower than expected when you've had chronic stress. So something important to keep in mind. Now, we also checked Ruth's levels 1 week after ovulation. and identified progesterone at her stage at this particular time happened to be really high. So she was at 23.7. Ideally, we say around 15 to 17. But look at what happened to her estradiol levels in the later half of her cycle. Normal is 80 to 120, and she was at 170. So think about this. This is a difference of probably about 2.5, maybe 3 weeks at most, of swinging from estradiol levels at 43 all the way up to 170. Now, you can imagine that if your estradiol was going to have that much of a swing, you're probably going to have some other symptoms that come along with that. And so that's part of what Ruth was experiencing, was this significant swing in her symptoms. One of the other tests that we oftentimes will look at is what's called glucose tolerance or insulin resistance. And it's very common to see that during this test, we're evaluating for what your body's response is when you have excess glucose or excess sugar. And so what we do is when you're fasting, we have you draw your labs, we check both your glucose and your insulin level. Then we have you drink a sugary drink. And over the next 2 hours, every 30 minutes, we check your blood sugar and insulin levels. Now, we don't do this for every woman. It is certainly just standardized based on your particular findings and your history, but it is important to check. And in this case, what we found with Ruth is that she actually had a pretty significant insulin response. And in some of these, she actually went over the normal limit for insulin, meaning her body was working much harder trying to produce a ton of insulin in order to keep these blood sugar readings under control. And so oftentimes we'll find this has to do with metabolism issues. It can cause ovulation dysfunction. And most importantly, in Ruth's case, it can add to weight gain. We oftentimes will see that insulin resistance makes it very challenging to lose weight. And we oftentimes need to talk through what are we going to do to effectively address this insulin resistance so that your body isn't kicking out so much insulin in response to every little meal that you eat. So Ruth's initial diagnoses that we had after evaluating her charting and looking through her labs was that yes, we confirmed she is perimenopausal. Again, her levels were not severe enough that she was in that menopausal range, and she's still having regular periods. So perimenopausal, insulin resistance as well. Again, as we just discussed, we had some insulin resistance, again, not diabetic level, but enough that it's potentially causing some problems. She also had thyroid dysfunction, and I didn't share her numbers in here, but she is one of those who her thyroid gland was normal, but she didn't have enough that was getting through on a cellular level in order to be able to bind to the cells and cause some significant thyroid dysfunction. And then adrenal insufficiency. And again, that's that low cortisol level. So really focusing on what are we going to do to manage stress levels. Again, we can't just flip the switch and turn off the stress, unfortunately, but how are we going to manage those pieces? So we always talk through kind of 3 different levels of treatment in our clinic. And first is that we always talk about lifestyle changes. And so we'll dive into that in a little bit here. The other is we talk about either supplement recommendations or food choices. So in particular, if you are lacking a particular vitamin or nutrient, or if there's something we know that helps to support good thyroid function, we will make those specific recommendations, again, based on your lab results. And then the third tier of the stool that we kind of look at when it comes to our treatment strategy is prescription strength medications. And wherever possible, we are always using bioidentical hormones when it comes to this. That includes our thyroids that we utilize. And primarily, we can get these through our regular commercial pharmacy. Many of them are generic, and so do not have to be crazy expensive. And we'll talk a little bit about a couple of those therapies that we use in a little bit. And then most importantly is that we want to target treatments to Ruth's cycle. Now, this is a very different strategy than just giving somebody birth control because we don't want her hormones to be the exact same every single day. That is not what her body needs. We need to be able to help her body to get into a regular rhythm that says, yes, I'm going to still ovulate. My hormones are supposed to peak how they're supposed to, and then they're decreasing when they're supposed to, so that we get back into and stay in this natural rhythm. And that's where we find that women feel their best, is when their symptoms are not just suppressed with a one dose, one size fits all medication, but when we can really augment what's supposed to be naturally going on with your cycle. So specific treatments, again, it's absolutely going to be dependent upon the diagnosis. And again, we're going to talk through all of these other pieces here in a moment. But ultimately, we're looking to correct that underlying cause of the dysfunction. And that's what we focus on in restorative reproductive medicine, is what we call root cause analysis, of identifying the problem, find the problem, fix the problem, and everything else will fall into place. So let's talk just a little bit as far as lifestyle recommendations for balancing your hormones. We're going to go a little bit deeper on a couple of these, but really we talk about 5 main areas when it talks about lifestyle. And again, please don't hear me saying that you have to overhaul every area of your life. But what I would ask is that if you could take one area of these topics that we're talking about right now and say, okay, if I can do this one thing, how can I help with my lifestyle in order to help balance my hormones? And I always am going to start with talking about food. So I'm really sorry because this is not a talk about diet, but food, when we talk about, especially during the perimenopause transition, we're going to talk about limiting or avoiding alcohol. We also talk about limiting or avoiding caffeine. I'm really sorry. I lose a lot of my friends when I tell them that. But the reality is that these particular substances can cause significant hormone fluctuations and make people feel a whole lot worse. Same is going to apply for processed foods and non-natural sugars. Anytime that we have those in our diet, our body is having to work harder to process them. And in many, many women, we find that insulin resistance makes it much more challenging to break these things down. So ideally, if we can focus on more colorful foods, that helps with our antioxidants. Things that are lower in fat helps to avoid cholesterol spikes. But I would caution here, I don't want you to go low fat across the board. We absolutely still need healthy fats in our diet in order to have enough cholesterol to synthesize all of our other hormones. So if every single thing you eat is low fat, that is also not great. This is more just saying focus on the whole food, good healthy fats where possible. Avoid any of the trans fats, saturated fats, any of that extra garbage, which oftentimes we're finding in our processed foods anyways. Next thing we talk about is sleep. And honestly, sleep is probably the very most important piece when it comes to balancing our hormones. So we talk about minimum of 7 to 8 hours of sleep per night. Now that's a minimum. Some people need more than that. It's also really important that we focus on good sleep hygiene. So this is going to mean absolutely no screens 2 hours prior to bed. Again, I lose lots of my friends when I say this. But the reality is that artificial light that's coming into our eyes can actually delay our onset to deep REM sleep. We need deep REM sleep because that's when our cortisol levels naturally spike, and it is subsequently when many, many of our hormones are produced is overnight when we're sleeping. So if we don't have enough total hours of sleep, and or if we don't have a high enough quality of sleep, it is really challenging for our bodies to restore and repair and produce enough hormones overnight. It's also really important to keep it dark in your room. If you can see your hand in front of your face when your lights are off, it is too light in your room, and that can actually lead to poor sleep as well. In many women, we also find that it can be part of the reason why you're having nighttime awakenings. If your eyelids are fluttering awake and you see light, even if it's a small amount of light that's coming in, it can trigger your melatonin levels to drop, which can then make you be more awake. If you're somebody who has night sweats, pay attention not only to the temperature in your room, but also the humidity. This can have a big impact when it comes to your body regulation of temperature. And then probably most importantly is try to have a consistent sleep routine. I know this is really challenging, and oftentimes we find that women on the weekends have a very different sleep pattern than they have during the week, but that can really set you up for failure if you are not sleeping well and sleeping consistently. So I actually have a couple of podcast episodes where I dive really deep into sleep. So episodes number 55 and 98 both talk a lot about sleep. How can we get better sleep, and how does that impact directly our hormones? And in fact, there's also a part in episode 98 where I also talk about how this impacts male fertility and male hormones as well. So this is not just for the females in the audience, but sleep is so important for our hormones in many ways. Exercise. We all know that it's good for us, but sometimes it can get challenging to do in the midst of busyness and life and work and kids and the daily shuffle. And so really it doesn't matter exactly what you do for exercise during this perimenopausal timeframe, but we talk about focusing on at least 15 to 30 minutes daily. Now, if you're doing more high intensity interval training, we say 3 days per week, but then you can balance that with some yoga, Pilates, stretching, and also really important to try and start incorporating strength training. So lots of great studies looking at the importance of strength training on preventing osteoporosis or bone loss. So ideally 3 days per week doing some sort of strength training that focuses on either resistance bands, hand weights, or even using your own body weight. And again, couple podcast episodes I list here where we go into detail talking more about exercise. How do I get enough? How do I not get too much? What's the sweet spot when it comes to my hormones and exercise? So supplements, there are a couple that I recommend that are good basically across the board, but there's a lot of them that are going to be very specific to your situation. So I'm always a fan of a good quality multivitamin. Now, some women choose to continue taking their prenatal vitamin, and that's totally fine. If you are somebody who gets a great range of fruits and vegetables on a daily basis, you might not need a multivitamin, but good to look for a good quality multivitamin. Calcium and vitamin D. Ideally, calcium we should be getting in at least 1,500 milligrams daily during this time frame. And this does not have to come just from supplements. It can absolutely come from food sources. I'm a big fan of getting everything through food where we can. So if you're not getting enough calcium in your diet from what you're eating, then you do want to make sure we're adding in that calcium supplement. And vitamin D3. Again, most of us that live anywhere north of St. Louis, Missouri, most of us are going to need some type of vitamin D supplementation. And ideally, we want to get those levels somewhere in the 30 to 40 range for overall good health. Fish oil and omega-3s also play a really crucial role when it comes to not only synthesis of hormones, but also into overall good brain health and good mental health. So we recommend a minimum of 700 EPA daily, and you can look at the side of your bottle to see on that. Again, if you're somebody who likes to eat seafood or gets your fish oil in that way, that's totally fine. There are other ways to get omega-3s in, flaxseed oil, chia seed, lots of other food sources. But again, ideally making sure that we get up to that 700 EPA daily. And so for many people, unless they're eating seafood on a regular basis, a supplement actually comes in handy when it comes to these omega-3s. Vitamin B complex. This one is especially important if you don't have a great diet or if you have recently come off of oral birth control pills. Birth control pills, it's well documented that it actually zaps our stores of B complex vitamins because it blocks our body's ability to absorb them well while we are on those medications. So really important to make sure that our B vitamins are supplemented. Again, you can do this through dietary sources, but if you're not getting a great variety of fruits and veggies, it's really important to make sure we have enough B vitamins. And then again, as I mentioned earlier, if you are somebody that has heavy bleeding and has low iron counts, we're always going to talk about some sort of iron supplementation or building it up through your dietary sources if needed. And then again, anything else beyond the top list that's here is going to be specific to your needs and physician recommendations. So I hear a lot about and have a lot of women that come in that want to be on antioxidants, this coenzyme Q10 or vitamin C. DIM is another really common one that women start taking during this perimenopausal time. Again, DIM oftentimes is utilized to help decrease your estrogen levels. But again, as we talked about with estrogen dominance, it's not always the right fit for everybody. So again, so important to look at your specific needs before just starting things across the board. And then L-tryptophan is another really interesting one. This is an amino acid, so it's a protein basis. And a lot of times the tryptophan can help with just kind of regulating sleep in a nice, gentle way without being on a sleep medication, without having to feel groggy the next morning. So that can be a huge difference when it comes to sleep. So I'm going to talk just briefly about a couple different prescriptions that we utilize. And these are going to focus primarily, again, on bioidentical hormone replacement therapy. So we're going to first talk about progesterone. And again, we're talking prescription strength here. Now, so incredibly important that this must be bioidentical. And what happens is that if we start to give our body artificial progesterone, first of all, you can really badly throw off your menstrual cycles. And second of all, it can actually suppress your cycles from ovulating, which can then further potentiate the problem. So again, as I mentioned, there is commercially available progesterone available at your regular pharmacy, and it's called Prometrium. This is generic. It is cheap. It is inexpensive. It is typically well covered by your insurance if you have insurance. Even if it's not covered by your insurance, we can usually get a 3-month supply for less than $30. So it is not crazy expensive. You can also get progesterone compounded, and we do utilize this in certain cases. Sometimes people have allergies to certain components in the Prometrium, or maybe they need a little bit different dosage. Or maybe they had a side effect from the commercial medication. But again, so important that this is bioidentical. And as we discussed with Ruth's case, important that we time the progesterone with your cycle to avoid further problems. If we give you progesterone continuously, it can actually completely suppress your cycles. And while some people think that's really cool to turn off your periods altogether, it actually can create more problems in the end as far as breakthrough bleeding, as far as thickening of the uterine wall lining, and other problems. So we want to time it with your cycle when it should naturally be occurring, which for most women is going to be in the second half of your cycle after ovulation has occurred. So, a couple great benefits that we see with progesterone is that almost within the first cycle, if not for sure by the second cycle, many women tell me my sleep is better, my bleeding has decreased, my PMS symptoms have decreased. Progesterone has a very calming effect. And again, it's not a sedative, but we do give it at bedtime because that progesterone does seem to just calm down the anxiety and the nerves and does tend to help with sleep. It also will counteract excess estrogen. So when we're talking about estrogen dominance, whether it's that picture of I have way too much estrogen to begin with, or I just don't have enough progesterone, that excess estrogen can cause heavy bleeding and can increase your cancer risk. So progesterone does a great job of helping to offset that excess estrogen and be able to help with more than just your immediate symptoms, but also long-term to help improve your symptoms. Now, I do want to say a little word about over-the-counter progesterone. So there's a bunch of different things that this is called. So wild yam extract is oftentimes touted as natural progesterone. So what I would say is that wild yam contains zero progesterone. The chemical structure is similar to progesterone, and that's why many women will utilize it in an attempt to try and help with their symptoms. Now, when people are using the over-the-counter versions, we find it does not raise your blood levels of progesterone because, again, it is not bioidentical. So it is not going to show up in your bloodstream in a significant way. And we find there's good research studies and data that show you only get about 5 to 10% absorption versus prescription strength progesterone. So I am not here to say you can't try over-the-counter progesterone, but please hear me that if over-the-counter progesterone is not solving your symptoms, it may just be that you need more. And that is absolutely normal and very common, especially during perimenopause when we see those progesterone levels start to tank. So take that with a grain of salt, but many times it's just not enough progesterone, and that's where we need the prescription strength medication. So let's shift gears a little bit to prescription strength estrogen. Now, oftentimes, like I mentioned during perimenopause, we're seeing this estrogen dominance picture, but in some cases, we start to see that estrogen levels are too low. And in those cases, we may end up supplementing with estrogen. Now, again, prescription strength estrogen must be bioidentical. One of the great things about estrogen is there's actually a ton of different versions of estrogen that are available that are bioidentical that are available through your commercial pharmacy. Now, unfortunately, there's not many of them that are in a great form that are super inexpensive right now. Many of them are still have patents out on their brand names, and so they do tend to be a little bit more pricey. So you can look for names like Estrace or Vivel. There are probably 20 different formulations of bioidentical estrogen that are available, or you can get compounded estrogen, again, from a reputable compounding pharmacy. Now, estrogen on the other side of things will tend to ease some of those symptoms that we get with low estrogen symptoms, things like hot flashes, sleep disturbance, bone density issues, and I'd also add on here vaginal dryness, vaginal atrophy. And oftentimes, if we're noticing specific vaginal symptoms, that's where we're going to want to give the estrogen vaginally. It helps to decrease your vaginal atrophy, so literally the thinning of the vaginal lining, and that in turn helps to prevent recurrent UTIs or urinary tract infections. Estrogen also is known to counteract bone loss, so either osteopenia or osteoporosis, because our bones need estrogen in order to build that good network and stay nice and strong. So estrogen does come with a few more risks, and so I'd like to include some of these here. And so definitely important to make sure that you're talking about this with your physician if you're getting prescribed estrogen. It can increase the growth of fibroids or reactivate endometriosis. And so it's important in these cases to make sure we're getting regular pap smears, we are getting an ultrasound done if needed to make sure there's nothing else concerning going on. There's an unclear link to breast cancer and uterine cancer. Initially, they thought that estrogen raised those risks, but when we looked back, it was actually estrogen that was not bioidentical, and the studies were not super conclusive. So more and more, we're saying estrogen is absolutely safe, and the benefits of it significantly outweigh these potential risks. There is also a slight increased risk in people that have heart disease, liver disease, or any history of blood clots or DVT. So if you are somebody who would be at increased risk for blood clots, we can discuss either a low dose oral medication for estrogen or topical. And quite honestly, in my practice, I've gone more towards just the topical estrogen, either estrogen creams or estrogen patches. As opposed to progesterone, estrogen actually absorbs really well in our system. And so that works really well to do that topically with the estrogen. So again, your case is going to be completely different depending upon what your needs are, but just wanted to give a general overview of kind of the two main prescription strength hormones that we utilize in our practice. And then other supportive treatments as needed. So again, as I mentioned, I am absolutely not opposed to antidepressants or anti-anxiety medications when needed. And in fact, there are some particular antidepressant medications that at lower doses are FDA approved to help specifically with hot flashes. And so I have used these in my practice before for women that specifically have hot flashes, especially if they either can't be on estrogen therapy for some reason or if they don't tolerate estrogen therapy. Again, we talk about iron replacement, and then always we talk through what are the other pieces of our team that can play a role in this. So counseling, therapy, support groups, a lot of times those can help as we're dealing with a lot of the other emotional pieces that come along with these changes. And then certainly if we find anything that requires surgical evaluation for polyps, fibroids, adenomyosis, we're always calling on our surgeons to say, hey, can you help us out with this? Is this something that would be amenable to treatment? Because again, if you're starting to experience heavy bleeding and you're only 37 years old, I don't want you to wait until you finally hit menopause 10 years later before the bleeding gets under control. So there are often times that we'll call in those other specialists if needed to help support your particular case. So what do I do now? What are my next steps and where do I go from here? First and foremost, I would humbly ask, share this information with others. If you had friends that would benefit from this or people that didn't get to attend this talk tonight, please share with them. It's going to be posted on our Facebook page for the next 30 days. After that point in time, Facebook removes all videos, and so we will then transition it to our YouTube page. So you'll be able to view it there, and we'll keep a link posted. We also would say go back and listen. There's a couple of particular Cycle Wisdom episodes where I talk all about perimenopause. So episodes 22 and 106 are myself. And then episodes 47 and 48, I actually interview one of my dear friends and colleagues, Dr. Sadaf, who is a menopause specialist. And she talks all about the importance of estrogen therapy when it comes to this time frame. So some great episodes if you want to learn more specifically about perimenopause. And then another thing that's really important is learn a fertility awareness method. We have tons of charting instructors that are able to teach you how to effectively chart your cycles. And this can really give you a good idea. Is this normal? Is this not? What do I need to do going forward? And then the other piece I would add here is that we do have free discovery calls. So if you're interested in working with us, there's a sign up spot on our website, radiantclinic.com. You can go there, fill out that form, and someone from our team will be in touch with you to discuss further. Is this the right kind of care for me? If needed, they can get you in touch with me, and I'm happy to personally give you a phone call back. But oftentimes people already know this is what I need. I just needed a couple questions answered. And that discovery call is the first step to working with us on a medical basis. So I'm going to leave this slide up here for a little bit. This is a way to learn more and stay up to date. Again, I list out here the Cycle Wisdom podcast. So if you're interested in learning more and listening more to other things that we talk about in our world of restorative reproductive medicine, you can go there and listen to other episodes. We talk a lot about fertility, a lot about irregular menstrual cycles, PCOS. What do I do if I have a teenager who's having irregular cycles, or how do I talk with their doctor about it? And then this QR code that we list here, this is kind of our eternal Linktree QR code. So it's a point where you can reach us for anything. So if you're looking to follow us on social media, find our podcast, sign up for a discovery call, all of that information is there on our Linktree, and we'd be happy to get in touch with you.